Good afternoon and welcome to today's Public Health Ontario Rounds. We are very fortunate to have Dr. Natasha Crowcroft returning to PHO to provide this virtual rounds presentation focused on congenital rubella syndrome prevention and the paradoxical effect. And I'm thrilled to be welcoming her and moderating today's rounds. My name is Dr. Sarah Wilson. I'm a public health physician here at PHO, and I work very closely with the immunization and vaccine preventable disease team. And on a more personal note, was very, very lucky and had the opportunity to work and collaborate with Natasha while she was at PHO. And I'll be providing a more extensive welcome and biography of Natasha after today's land acknowledgement and some short housekeeping details. Today's rounds are being presented to you from a place we call Toronto. But for thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, the Haudenosaunee, and the Mississaugas of the Credit. This land is covered by Treaty 13 signed by the Mississaugas of the Credit, while the province we serve at PHO is covered by more than 40 treaties and other agreements, as well as unceded territory. Ontario has been and is still home to many diverse Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. And I acknowledge this as part of Public Health Ontario's commitment, as well as my own personal commitment to truth and reconciliation. So before I go on to introduce Dr. Crowcroft, I've been asked to share that I have no conflicts of interest to disclose as part of my role here as moderator today. So as I mentioned, I'm very pleased to introduce today's speaker, Dr. Natasha Crowcroft. Dr. Natasha Crowcroft currently serves as Senior Technical Advisor for Measles and Rubella at the WHO, World Health Organization in Geneva. She also, as many of you know, has connections to Toronto. She is an adjunct professor at the Dalalana School of Public Health. She was the inaugural director of the Centre for Vaccine Preventable Diseases and is a senior fellow at Massey College, University of Toronto. Dr. Crowcroft has extensive experience in public health spanning more than 3 decades and over 300 scientific publications, and has played a number of very important leadership roles in public health in Ontario and in Canada. And I'll just briefly summarize some of them here. Roles such as Chief Scientist at Public Health Ontario, Professor of Laboratory Medicine and Pathobiology at the University of Toronto, Adjunct Scientist at ICES, and was a member of Canada's National Advisory Committee on Immunization. So thank you, Natasha, for your leadership in these roles, and we're very excited to learn more about your role in global health policy at WHO through your presentation today. So I'll hand it over to you now. Looking forward to your presentation.
Thanks very much, Sarah, for that lovely introduction, and greetings, everyone. Good morning, good afternoon, good evening, depending where you are. I'm thrilled to be here today, partly because this is a topic very close to my heart. I'm hoping to try and connect some of the global work that goes on to the local work that happens within countries. So that's one of the key things I want to achieve today. And I'm also think for those of you who happen to have known me in the past or know me now, it's a chance to talk a bit about what it's like working at global level and what I've been up to since I left PHO about 5 years ago. So you have the title already. As a disclosure, there's a disclaimer from PHO that I've been asked to include that this is created by the author, myself, and so PHO is not the owner. There's no application. Any application or use of this information is a responsibility of the user. So this is our liability statement, I guess. And for myself, I have no potential conflicts of interest to disclose. So the learning objectives, which were included in the information about the presentation, to describe inequity in countries' access to rubella vaccine and the implications for the global burden of congenital rubella syndrome and rubella elimination, to describe the paradoxical effect as it applies to immunization coverage, to outline the key elements needed to change global immunization policy and apply this global case study to the elements needed to strengthen local public health policy development. So the outline of my presentation, I'm going to do this in 3 parts. The first is to talk about what the public health policy problem is. Then I'm going to talk a bit about what it took to change public health policy. And then I'm going to finish up with the outcome of our work and the lessons that we learned and that can be applied locally. So to start with the public health policy problem. So rubella virus, it's an envelope positive stranded RNA virus. There's a picture of the virus here. And In terms of public health ability to control this infection, it's great that humans are the only host. We don't have to worry about animals or the environment. It's just us. And so this makes control much easier. Rubella virus itself, it causes a mild macular papular rash. It's not a serious infection in most cases. And about between a quarter and a half of all cases are actually have no symptoms at all. But its big issue is during pregnancy. So infection in pregnancy can cause miscarriage, fetal death, stillbirth, severe birth defects. And this is congenital rubella syndrome in the picture, which is this is what we're trying to prevent with our rubella immunization programs, is this very severe effect on the outcome for infants when they're born with this really devastating syndrome. So I've put up here the table from the Canadian National Case Definition. I'm not going to go through the whole case definition because you can look it up. The table's in two parts. That's not for the confirmed case definition. That's the divisions really for probable case definitions, just in case you're wondering why there's a column A and a column B. For the confirmed one, it can be either side. But the reason for putting up here is that the predominant manifestations are these eye problems. Cataracts is the typical thing that led to the original discovery of this syndrome. Heart defects very frequently manifesting, hearing loss and other eye problems. And then in the column B, what this illustrates very well is that this virus can really damage nearly every system in the body, but particularly the liver, the spleen, the brain. It causes this range of very serious effects when when a fetus is infected during pregnancy. So it's a very nasty syndrome that we can prevent completely through immunization. And I've included a paper about this, about the outcome of infection. And the reason for including this is two reasons. One is Liz Miller, who wrote this paper, was a former boss of mine, who's absolutely fantastic, one of the most brilliant people I've ever met. But the other reason for including it is because this is a study that's published in The Lancet back in 1982, looking at women who are infected during pregnancy and what happened to their infants. And what was done was they used data from the Public Health Laboratory Service and followed up the women. So they identified women who were infected in pregnancy through the Public Health Laboratory Service. And I included this because it's a really lovely example of how important it is to have very good public health data, our surveillance information that's collected, and very strong public health agencies that are able to follow up on the data that we use every day in public health. And this is one of those studies that showed how important the timing of the infection was in pregnancy. So all infants in this study who were infected before the 11th week of pregnancy developed problems, had defects, mainly congenital heart disease, as I mentioned before, and deafness. In a later period, 13 to 16 weeks, they were still affected. That was just deafness. And then women who were infected later in pregnancy, there were no defects attributable after 16 weeks. So it's observational data. It's not like a randomized controlled trial. That's information you'd never get on a disease like this, but absolutely critical. And it came out from the Public Health Laboratory Service, which is a similar model to what exists in Ontario today. I used to work with the late Dr. Lewis Cooper, and these are some pictures courtesy of him of a child who was born in the 60s when there were a lot of outbreaks of rubella going on in North America. And this child showing her at different stages of her life, from when she was an infant through to an adult with severe developmental delay with cataracts and deafness. So it's just to illustrate that it's not, often you see the pictures of the babies that have congenital rubella syndrome, but the children that survive, this is a lifelong commitment to their parents to care for them into adulthood. So why is this relevant to Canada? As I said, is this a really niche topic to be talking about? And rubella and congenital rubella syndrome are eliminated in Canada. The important thing to emphasize is that that the progress that's being made on rubella elimination reduces the risk to Canadians. And there have been cases of congenital rubella syndrome that have happened in Canadians who have visited endemic countries during pregnancy. And so the only way to really fully protect the people who live in Canada is to eliminate rubella everywhere. And the other way of thinking about it from a more health economic perspective is this is an investment that Canada's making in rubella elimination here in Canada. And the best return on that investment is when rubella is eliminated everywhere. And then Canada can actually eventually stop immunizing altogether, as we've done for smallpox. So this is relevant, both personally to Canadians, but also to our whole system. We have a vaccine that is 95% effective. It confers lifelong immunity, and not many vaccines do that. Usually the RA273 strain, developed by Stanley Plotkin and Leonard Hayflick. And it is usually given in combination with measles-containing vaccines. There used to be a standalone rubella vaccine available, but virtually everywhere now, rubella is given alongside measles and other components, whether it's mumps vaccine, varicella vaccine, or others. So measles and rubella are really closely tied together now in terms of their progress in the world. So moving on to the WHO recommendations. So we have a WHO recommendation for measles vaccine coverage threshold for introduction of rubella-containing vaccines of 80%. And this is where I'm starting to get to the paradoxical effect. This is a threshold that prevents countries from introducing rubella vaccine, and it was set in the 2000s. So back in 2000, countries were advised they could introduce rubella-containing vaccine into their immunization program if they could achieve this coverage level in their routine immunization program, based on what they were doing with measles, on the understanding that measles and rubella would be given together. In 2010, this recommendation was updated to say that countries could introduce rubella vaccine if they could achieve this 80% level, at least 80% level, either through routine immunization or through follow-up campaigns. And if they also conduct what's called a wide age range campaign from 1 to 14 years prior to introducing this vaccine. And then in 2020, the rubella position paper was updated, and those recommendations were maintained and grandfathered over. It was always known that this 80% threshold was conservative, but it was felt that it was needed to have a wide range of safety because of concerns about the paradoxical effect. So we're getting there. We'll get there eventually. Before I talk a bit about that more, I just want to explain what follow-up campaigns and catch-up campaigns are, because this is probably not familiar terminology to people working in Canada that doesn't use them or doesn't need them. So a follow-up campaign, they use very widespread in the rest of the world in countries where coverage is low. And these are campaigns designed to reach children who've been born since a previous campaign, because these are all happening in countries that have regular follow-up campaigns, to fill the gaps that are left behind due to suboptimal routine immunization coverage. So basically, they're reaching the kids that have been missed in the routine program. They get caught up periodically, and the periodicity depends on how low coverage is. If coverage is about 80%, then you're talking about every 4 years having a massive campaign to reach children under 5 and pick up all the kids that were missed. In contrast, a catch-up campaign is specific really to rubella, and it refers to a one-off, single wide age range campaign that is put in place to reach the older children who are not going to be reached by the new vaccine that's coming in, that's given to young kids. It's those older children who probably, as a result of a new vaccine coming in, they won't catch rubella, but they won't get vaccinated. So if they don't get caught up in this catch-up campaign, then there's a risk that they will grow up to be adults who are susceptible to rubella. So these two different strategies are current WHO policy, and they're alongside this threshold of not being able to do anything until you reach that threshold of coverage. So what was this 80% threshold designed to prevent? And here, as a bit more background to the concept behind the paradoxical effect, it'll be familiar to some of you that infectious diseases have different effects at different ages. So if you think of polio or hepatitis A, these are more severe in adults. If you have very high rates of transmission, most of the infections will happen in young children. But as you go through a demographic transition and as hygiene improves, that transmission slows. And so these infections can move into older age groups and become more severe. There are other infections like pertussis and respiratory syncytial virus, for example, and they're more severe in infants and less severe in older age groups. So this average age of infection can change for various reasons. I just mentioned an environmental reason. You improve hygiene, you slow transmission. If you think of COVID, the non-pharmaceutical measures that were put in place of social distancing, those all reduce transmission. So there are various things that can be done to change the patterns of transmission. But one of those is also demographic change. As we have smaller families, as countries move away from large families, high birth rates, close, younger first age of mother at first childbirth, and smaller gaps between kids, and you move to a place where the first baby's born when the mother's older, where there are fewer children, where there's bigger gaps, that changes the transmission of infectious diseases. You can also get these effects if there are sudden changes in populations, like mass migrations of people, refugees, for example. And the other intervention is immunization programs. They can change the age of infection because they change the rate of transmission. So if you introduce an immunization program and either the vaccine doesn't give 100% protection or the coverage is incomplete, then it can just slow down transmission. And that means the average age of infection will increase. And that average age of infection increasing means that more susceptible people will be found in older age groups. And of course, that's a huge issue for rubella, because if you have more susceptible people in older age groups, then that's an increased risk of congenital rubella syndrome resulting from an infection during pregnancy. Now, all of that increase in average age of infection that we see with infectious diseases is, we know this happens. It happens with lots of different diseases for different reasons, as I just said. The paradoxical effect with rubella is something that goes beyond that. So it's that increase in risk of congenital rubella syndrome, but it's where you actually exceed the baseline. So it's where the increase is so great that you have more cases than you would have had with no program at all. On the left panel here of this slide, you see the introduction of vaccine and then the fall in incidence, followed by what can happen with low coverage, which is a rebound increase in cases of rubella and congenital rubella syndrome as a result. And with that increase, what you get initially is a reduction in CRS because of the reduced transmission. And then in the other panel, on the second panel, you can end up with, at the end of this reduction, actually surpassing the level of CRS cases than you had at the beginning. So this is the worst case scenario. You get short-term benefit, but long-term harm. And this is the thing that has been hammered home within the immunization world for rubella for so many years, that this 80% threshold has been really a very, very iron bar fixed. You cannot introduce, you cannot introduce this vaccine if a country does not exceed this threshold of coverage. Is there any evidence from sort of real world data that this is a real effect? And here I've got two examples of countries which are used as examples. I've used the example of Greece in teaching about the paradoxical effect. Greece and Costa Rica both introduced rubella vaccine in the 1970s with low coverage. They had no catch-up campaign at the time. It wasn't recommended then either. It wasn't WHO policy. They had many years of very low coverage, below 50% for periods of time. They had no targeted efforts to reach susceptible age groups in the 20 years between the introduction in the 1970s and the 1990s, when these two figures are from. So they did everything that we would expect to lead to a subsequent increase in rubella. And that's what that's what happened. What we don't know is whether this was a true paradoxical effect, because we don't have data to be able to show whether they exceeded the baseline in paradox, in CRS. So we don't know if they met the definition, but they definitely had an issue which is shown in terms of cases for Greece in the figure from the British Medical Journal, where you see in green this epidemic of rubella, followed, as you'd expect, with a delay with the birth of children with congenital rubella syndrome. So it was a terrible situation in Greece, and a similar thing happened in Costa Rica. What I've shown on the right is is actually two serosurveys, so showing the utility of serosurveys, where the dotted line is from 1996, but the solid line is back in 1969. And what you can see in the solid line is that with age, the proportion of the population that was immune to rubella increases, as you'd expect, with transmission of rubella. In 1996, after the introduction of rubella vaccine for more than 20 years, you see this dip in the older age group, where there were more adults susceptible to rubella in that older age group. And that is a result of the immunization program. And with that slowing of transmission, this means that more women in pregnancy would have been susceptible to CRS and therefore at risk when outbreaks of rubella occurred, which they did. So we know there's an issue, but neither of these countries actually followed the other two components of our current policy, which is to introduce rubella vaccine with a wide age range catch-up campaign, and to have regular follow-up campaigns if coverage is low. So hopefully that gives you a sense of what the paradoxical effect is about. And the reason we came to this right now is because this 80% coverage threshold is a massive equity issue. It's a barrier that's causing ongoing equity. So we're now having data from 2019, modeling data from 2019, about 32,000 children a year being born with congenital rubella syndrome, most of them in countries where there's no access to vaccine, and 98% of them are being born in low income or low middle income countries. And what the figure shows is how nearly all countries in the world have introduced rubella vaccine except for low income countries. And they're shown in the bottom dotted line, where you see there was some increase up to 2019, but from 2019, there's really been no progress on introduction of rubella vaccine in those settings. And so we've reached as far as we can go with current policy, and we're now stuck with this massive inequity. What this is showing you also is where these countries are. And the majority of the countries with congenital rubella syndrome, most of them in, as I said, countries with no rubella vaccine. Most of those countries are in the African continent. Indeed, in WHO regional terms, there are 4 countries that are in the Eastern Mediterranean region, but 3 of them are in the African continent, and one of them, Afghanistan, is not. So we have 19 countries that are yet to introduce rubella vaccine. But in the rest of the world, rubella has been verified as eliminated in 92% of countries by 2023. And just to say, that's not the answer to the question that I asked at the beginning, because that's the proportion of countries in the rest of the world, not in the whole world, that have eliminated rubella. It's 92% in the rest of the world, excluding these 2 regions. But it includes the whole of the Americas. So the whole region of the Americas has been verified as having eliminated rubella since 2015. And this is a certificate which Dr. Lewis Cooper has signed. And you'll see I also signed because I was part of the committee that verified. So we have a situation of this huge inequity with children not having any access to rubella vaccine, and as a result, babies being born with this devastating syndrome and dying. And these are some of the poorest countries on earth, and also it's a really large population. There are 3 countries in the African continent that sum up to nearly 500 million children if you add up Nigeria, Ethiopia, and the Democratic Republic of Congo. So there are really large countries that haven't introduced a rubella vaccine yet. And so and then the rest of the countries that haven't got access to the vaccine, they really are some of the poorest countries on earth. So here's a list of the countries that are. Some of them are listed as pending because they have in the past actually reached the threshold, but right now we don't know if they're eligible because they haven't had their most recent follow-up campaign. There are 6 countries here that are planning implementation, so that's really good news. But there are 10 countries that do not reach the 80% threshold and don't have any prospects of doing so in the near future. Their measles containing vaccine coverage ranges between about 41 to 76%. All of these countries rely on measles follow-up campaigns to prevent measles outbreaks, and all of them would benefit from the wide age range measles rubella vaccine introduction, not just for rubella, but because these really huge campaigns, you imagine immunizing every child under 15 years of age, they're massive interventions, and they have a huge impact on measles prevention. And most of the deaths from measles in the world also occur in this region. So there's a huge opportunity to not only have a big impact on the equity and prevention of congenital rubella syndrome, but also to prevent measles. So what did it take to change global public health policy? So I'm moving to the next stage in my presentation, having given you a lot of context. And I wanted to start with this idea that changing policy requires open minds, because in public health, we have a lot of rules and regulations and things. We often don't have great evidence for some of our policy. I have to say this, we're not as good as other areas. Like, for example, in the cancer field, there's an ongoing, really strong research-centered approach to finding evidence. How do you improve treatment? How do you improve survival? We've not been as good in public health at questioning our policy and generating good scientific data to underpin it and to move it on and to move it forward and to improve outcomes. But in order to do that, you need an open mind and the willingness to think differently about a problem. And the other thing that helps is a burning platform. So that's a burning platform refers to a situation where if you don't do anything, something's going to go wrong. And the thing that really got us moving on this problem is Kurt Frey coming to speak to us about, as a global community, about some work he was doing at the time. It's now been published, but it wasn't at the time, looking at the impact on demographic change and how that was going to increase rates of CRS. And this is a panel from his publication, shows on the left if you look at the blue line, this is the impact of demographic change. The smaller family sizes that I was talking about will reduce rubella transmission. And the impact of that means that if we don't do anything, these countries that don't have vaccine at the moment, and that again is the blue line at the top on the right, will have an increase in congenital rubella syndrome, regardless of the introduction of vaccine. So this made us all sit up and think, right, it's not only a difficult situation anyway, we have to do something about this now. So you need to be open to people coming to you with new ideas and think them through. And in order to change policy, we needed to understand the context we were working in. So as you may be aware, the World Health Organization is the global health policy-making authority. But we had to, in order to get anything changed, we had to make sure that any work we did was reviewed by 2 groups. One is the technical work needed to go to the Immunization and Vaccines Research Advisory Committee. And they translate modelling work to support evidence-informed decision-making within immunisation programmes. And the other group you may have heard of is the WHO Strategic Advisory Group of Experts, SAGE, and they advise WHO on global policies and strategies. So this is the context we were working in. We needed to figure out how to get the work, if we were happy with it, to these groups and get it out into the world. And the way we did this was working through a global partnership called the Measles and Rubella Partnership, which is a fantastic group of people. This partnership is part of the Immunization Agenda 2030, which is our broader global strategy. And we have a responsibility to implement the global measles rubella strategic framework. WHO sits in the permanent co-chair of this partnership, and so that's part of my role. And then we set up a task team to look at this problem specifically, and that included experts from the partnership, but also from the Vaccine Impact Modelling Consortium, and had the goal to determine how to reduce congenital rubella syndrome, the burden, but also how to reduce inequity. And this idea of inequity is I think that was a very important value that we took right the way through the work to make sure that it was like a guiding principle. How do we make sure that we reach these children and make life better for future children? And we also had our objectives to reduce the future burden, to avoid paradoxical increases, to enable rubella elimination, and to align with our global strategy. So we had this task team, and we started speaking to people, and we started hearing about the work that was being done on the modelling side and trying to discuss it with various groups. And I put this slide here because it's a bit difficult to put it. I wasn't sure where to put it in this presentation because we were getting feedback all the way through the process. But I thought it was probably important to put it here so you understood kind of why we ended up working the way we did. And also, I think it is relevant to changing policy anywhere. And how in the process of talking to many different people, how important it was to listen so that when we finally got to SAGE, we would be addressing all of their questions up front. So the kinds of things we were getting were comments like, this is too high risk. If you do get it wrong, it could undermine the whole program. You know, if you're wrong about this paradoxical effect, this could undermine the whole program. So this made us stop and say, okay, it's imperative to make a very robust evidence-based case for policy change. We were going to do that anyway, but we were going to spell it out so clearly and make sure that everybody understood what the basis was for what we were saying. We had comments like, I don't believe in modeling. I don't, you know, so some people don't believe in modeling. This was literally what somebody said. So we thought, well, we may not be able to change their minds about modelling, but we can include different types of evidence to support the results. We had comments such as, we don't believe these countries can implement campaigns, this won't work. So we decided, well, we need to make sure part of our work, we have to include credible witnesses and credible sources to make sure we show that these countries can do what we're proposing. We also had comments like, it's like being in court where we've been questioned as an advocacy group, not as a scientific group. And so we made sure we talked about what the role of the MNRP, this Measles and Rubella partnership is, and how we're not an advocacy group, we're a partnership which includes technical agencies. And we also had questions about, you know, what exactly you're asking SAGE. And so we were very clear about the policy question we were asking. We're only asking about dropping the 80% threshold so that countries could introduce the vaccine. We didn't want to change any other policy recommendations on the wide age range catch-up or anything else. And we also changed the name of the session that we were proposing for SAGE to CRS prevention. And the reason for that was to focus on equity and the values that we were holding. It was a very complex process, so there's a lot to say about this. But I'm trying to, so I know there's a lot here to think about, but I'm trying to give you a sense of really how dense the work was. So whenever you do something like this, you have to expect a lot of process in addition to scientific review. We presented the process, as I said, at multiple internal meetings to get feedback. And then we settled on this final sequence. I mentioned this committee, IVORAC. And then we also had a SAGE pre-meeting, which I'm not going to talk about, but that was to make sure that the SAGE members had a really good chance to dive into the modelling before we got to SAGE itself, which is the final session at just in September last month in Geneva. So the step one was going to this committee, IVORAC, for the review of the modelling methodology. And I'm just going to present one paper from that, this one from Nigeria, which is the work by Matt Ferrari and his colleagues. We also presented on the work that was conducted in the Democratic Republic of Congo. So this is work done for Nigeria at subnational level. And what they found using, and this is a shout out to seroepidemiology, they use serosurveys to get new estimates of the basic reproduction number of rubella, which everybody knows about, the basic reproduction number post-COVID. So it's very important for setting thresholds for coverage, the coverage you need to reduce transmission of rubella. And they found that the estimates were lower than the estimates used for that modelling back in the year 2000, more than 20 years ago, for the setting of the original 80% threshold. Similar findings from the Democratic Republic of Congo. What you see here is they were previously working on estimates of the basic reproduction number of around about 5. What you see in this figure is that the national level, which is the red dotted line, is around about 4, and in many parts of Nigeria it was lower than that. And what you see in the map is the difference between the north and south. There's high transmission in the north, which means actually there's a lower risk of CRS because more children get infected as when they're younger, and a higher risk in the south, where the R0 is actually lower. So this work was presented, the DRC work was presented. We also mentioned that we were doing some scenario modeling, which I'll talk about in a moment. The conclusions of IVORAC were that the modeling methodology was appropriate. They welcomed additional projection modeling that we talked about. They also emphasized the need for transparent, nuanced, and contextualized communication. So it's interesting. I put that in there because IVORAC is a very methodological committee, but they were also concerned about how the findings would be communicated. So that was a flag that this committee made that recommendation. We went on to present the modeling to SAGE with the scenario results that I mentioned, and I'll talk about those shortly. The next step was presentation. So I'm not talking about the presentation, the modeling presentation to SAGE pre-meeting. But when we got to SAGE, we made sure we presented a lot of observational data. So here's the answer to that question about what proportion of countries in the world, in the whole world, have eliminated rubella. And what you see here in the bar chart is that huge increase, with 99 countries in the world have eliminated rubella, and that works out at 51%. So those of you who said 51%, congratulations, you were right. 51%, more than half of the countries in the world have have been verified to have eliminated rubella. We also presented incidence data. Here you see incidence, it's calculated 3 different ways. Don't worry about that. The main message is that however you cut it, the top row, not eliminated, no rubella vaccine in the program, when 0 coverage, they have very high coverage if you compare it with all the others. So there are countries that have introduced rubella vaccine but not yet eliminated. They have less than 80% coverage. They have really reduced their rubella incidence. 80% and above, they've reduced it even further. And the bottom 2 rows are rubella verified as eliminated, and those countries have essentially zero incidence. So this vaccine has a phenomenal impact on rubella transmission once it's introduced. We had 2 people presenting, one from the African region, one from the Eastern Mediterranean region. They reported, Belcher, my colleague Dr. Masresha, reported there's big appetite for rubella vaccine introduction across the region. Countries that had introduced had found this big reduction in rubella incidence. There have been outbreaks of rubella, we can't deny it. But there's ample country experience in conducting wide age range campaigns, so speaking to the feasibility of this. And in the Eastern Mediterranean region, again, the 4 countries that are left to introduce are keen to introduce. Pakistan and Afghanistan are very closely linked epidemiologically. We found that from polio. So important to get on top of rubella in Afghanistan for both countries. They have extensive experience in conducting SIAs, including in countries like Somalia, Sudan, Yemen. These 3 countries eliminated polio despite conflict and instability and humanitarian crises. So very positive messaging from our colleagues in the field. In terms of the mathematical modeling, the scenarios I talked about, this is a summary of the scenario modeling. To talk you through it, the RI is routine immunization, which is they modeled based on keeping routine immunization exactly the same over the next 30 years, or the duration of the modeling. Then the basic different scenarios, they are currently recommended and these are all 19 countries, if we follow currently recommended advice to have a catch-up campaign and a follow-up campaign and keep routine immunization exactly where it is. If you look at it, all the countries are green on this, so they will all be fine. There will be net benefit, there'll be no paradoxical effect. If you have a not ideal scenario where the follow-up campaign coverage is only 60%, which is way below the 80% threshold, you still get no impact in terms of a paradoxical effect. All these countries are green, so we're still good to go. If you get to this next scenario, set of scenarios, I should say, where this is one in which the catch-up campaign is only up to 5 years of age, you still get no impact. You still have no problem. The only situation in which you have a problem is this worst-case scenario at the bottom, in which no follow-up campaigns are conducted. And even then, most of the countries are green on this. If you look at it, there's only 5 countries, 6 in the very worst one where there's no catch-up campaign, but 5 countries with a catch-up campaign and no follow-up campaign that would have potentially an issue. And the numbers in those boxes are the numbers of years it would take to have an issue, which means there'll be many years to fix a problem before you get there. So the summary of this very complex modeling is that we're good to go with current policy. If we implement current policy, there will be no problem with a paradoxical effect. There'll be net benefit for all these countries, and there will be potentially elimination of rubella in many of these countries. So the conclusions from the work that we did, the observational data from the modeling as well, is that the evidence for the 80% threshold has changed. We have programmatic evidence showing that rubella incidence falls when rubella vaccine is introduced. That we've managed to sustain elimination of rubella in all these countries is really good evidence how robust rubella vaccine introduction is. That our current policies of the catch-up and follow-up campaigns are effective at reducing rubella transmission, and that these strategies are feasible. The modeling shows that the R0 that we were working on is lower than previously assumed, that the demographic change will increase CRS, so we will be in trouble if we don't do something now, and that the routine immunization that we have right now is sufficient to prevent the paradoxical effect in most countries. And once you add campaigns and the follow-up campaigns, it will prevent the paradoxical effect in all countries. So I'm going to have to whiz through the conclusions that we ended up with. So in September 2024, we got the outcome we wanted, which was SAGE recommended universal rubella containing vaccine introduction. It recommended lifting the requirement for the 80% coverage, and recommended introduction of the vaccine in the 13 countries yet to introduce the vaccine, plus there are another 6 that are in the process. SAGE reinforced the current policy for the wide age range catch-up campaign and for the regular follow-up campaigns. So the lessons learned on changing policy, I think, to finish on this, you need to be looking for new evidence all the time. So we weren't looking for this. A modeler came to us saying, I've done this work. I think this policy is really wrong and we need to do something to change it. Don't take the evidence base for policy for granted in public health. And we need to be thinking about this all the time and be open to change. Have a clearly defined problem to solve, a policy question and a defined pathway to changing policy. Have good partnerships between academia, programmatic and field experts. You need the right people in the room. You need clarity on who needs to be convinced, so be listening and thinking and creative about how to build the constituency around it and assemble the right kind of evidence. It can't just be modeling, it can't just be observational. You need to bring it all together and add the public health wisdom which you need to really say, is this feasible anyway? And then drive public health policy forward and using data. Use values as your guiding star. And remember, at the end of it all, you're going to have to implement the policy. So that's the work we're involved in now, is trying to figure out how to implement the policy, because there's literally millions of children that are going to need to be vaccinated to get these vaccines into use in all these countries and in some very difficult environments. So the likely impact is that millions of children from 9 months to 15 years will be protected, and they mainly live in the African continent. Tens of thousands of children per year will not be born with CRS. This is what public health is all about. And the projected future increase in CRS will be prevented. And it means that rubella elimination in the African and Eastern Mediterranean regions is now possible. So the other thing to mention is that measles, rubella wide age range catch-up campaigns will prevent many deaths from measles as well in a continent where most of the deaths from measles occur currently. So that was a lot. I want to thank all of my collaborators on this work, and thank you very much for listening, particularly the other people who are at the SAGE session, and happy to answer any questions, and handing back to Sarah. Thank you.
Thank you so much, Natasha. That was just excellent. Thank you for a fantastic presentation. I think so thought-provoking, and thanks too for making the connections to us in Canada and opportunities for thinking about creativity and other solutions for impacting policy. So we have about 10 minutes left in the session. I'm looking at the Q&A pod and encouraging people to, from our audience to pose any questions that you might have to Natasha there so that we can make the most of our time with her. So really encouraging participants to list questions there. And maybe I'll get us started. I don't see any questions posed yet, but Natasha, if I can maybe ask you a question. As I mentioned, I really loved that slide that you included around lessons learned for changing policy. And one of the things that you noted there was bringing together data with experiential public health wisdom. And I wonder if you can maybe elaborate a little bit more about how to do that and maybe how to do that well, especially as advisory committees are moving towards more structured tools for evidence syntheses, things like GRADE, where experiential public health wisdom probably doesn't factor into that schema so well. So what's your advice? Like how can we actually bring that experiential public health wisdom to processes that use GRADE, and how do we do that well?
Thanks very much for the question. It's not, it's a complex situation because it depends really on the advisory committee in the context of that. I would say one piece of it is think about the communities you're serving and who best represents them. So if you're working on a policy that's going to affect a particular community, how are you making sure that community is represented somehow? And when I say represented, it may not be, I'm not talking about somebody from the community necessarily being in the room, although sometimes that is an option. It's more about making sure that the folk who work with those communities are represented in some way. I think in my experience with committees like NACI and actually with SAGE, there's been a focus on people with expertise in say in vaccines, for example. Now, of course, you need expertise in vaccines for SAGE. But if you don't have somebody who is from the public health side who understands about the implementation of those vaccines, there's going to be a big gap there. You could end up with a recommendation that really isn't feasible. So that's kind of the easier end of it, of how do you think through what kind of expertise you need in the room. I'm a strong believer in there being very close networks between government and public health agencies, and between technical people in public health agencies and the more the policy implementation side. I was listening to a podcast about how during COVID, how there was an initiative to bring data science and modeling people into government to speak to some of the government officials and try and really get them on side with what the data are really about and communicate effectively. It's not, it requires development on both sides, because policy, and that was an example of trying to achieve that, where the policymakers need to make the effort to try and understand where the technical folk are coming from. But the technical folk also need to develop the skills to be able to communicate quite complex areas of methodology to policymakers. And I think the best way to do that is to have multiple opportunities to interact, not to just be a kind of one-off dog and pony show, but for there to be a connection there. We were very lucky in this CRS work to have really excellent modelers who were very well versed at communicating their work in a way that was very accessible. And I think, when you hear these comments like, I don't believe in modeling, I understand where that's coming from, because if you're not a modeler, it is a black box and you have no idea, and you have to take it on faith, that the answer is X, and you have no idea what went on in this black box. And if you're working with the right modelers and the vaccine, this VIMC group that we're working with, they're very well versed. They have their modelers, many of them are embedded in public health organizations. Where I used to work in the UK, the national agency had a modeling group inside the organization. And so that familiarity and on both sides, the policy makers and the data technical experts working side by side, that was really critical. So hopefully that's kind of answered your question.
Yeah, no, that's excellent.
Relationships
Thank
are
you.
really key.
No, that's great. That's great. Thanks. Thanks for that great response and those reflections. So, so I'll note that in the comments, there's also some, warm welcomes back to you, Natasha. And I think lots of wonderful feedback in terms of the presentation. We have about 5 minutes left, so I will pose, I think we have a couple of questions here. And so one is, rubella coverage in the 13 countries has been recommended, but has the funding been secured? So I wonder if you could speak about that aspect. And then the follow-up question to that was asking if the paradoxical effect that you highlighted, if you could maybe provide some examples or answer the question about whether it's been observed with any other diseases.
Sure. So, I didn't say a lot about the Measles and Rubella Partnership in terms of emphasizing the membership. So the Measles and Rubella Partnership has the three technical agencies, which are WHO, UNICEF, and CDC. So we're the nerds in the group. And then we have Gavi as a member of the MNRP, the Bill and Melinda Gates Foundation, so they're on the donor side, with the UN Foundation, so they're also a kind of resource mobilization group, and with the American Red Cross, who are more of an advocacy group, but they also have some technical staff, and they represent communities. So we have quite an interesting mix of people in the partnership. But one of the members is Gavi. So the answer to the question on Gavi is the beauty of doing this within this partnership, and this is about having the right people in the room. I mean, it's a great question. We had Gavi in the room all the way through. So when somebody asked the question, like, well, is Gavi going to pay for this? The Gavi person said, oh, well, we knew it was coming, so we put it in our finance plans for our next period of 5 years, or I can't remember the time period, but so it was like, the box was ticked before it even came out of Sage. So this, in the old days, WHO would have set up a working group of experts who would have then come out with their recommendation, and then it would have gone to Gavi, and Gavi would have had to, figure out whether it could implement. Now it's all done seamlessly, woven together, and that's the beauty of being in the room together. On the paradoxical effect in other diseases, I don't actually know. I can't think of anything. Rubella's kind of the example we always use. And as I say, the two examples we refer to are Greece and Costa Rica, and we're not even sure if they really are in terms of, definitely it was a problem, which we've learned from and changed policy, but we don't know whether it actually truly was a paradoxical effect. So, yes, I'm not aware of any, but maybe other people know. We do know that this problem of moving the age range of infection is very much real. The question is whether or not it leads to actually being in a worse place than you were when you started, and that I'm not aware of very many examples outside rubella, and so sorry, I'm not doing very well on that one.
I don't think there is I'm not suggesting there is an answer to be provided. So I appreciate those reflections. It's really helpful. So it looks like we've run out of time because I have a few sort of short housekeeping notes as we close out today's session. So Dr. Crowcroft, thank you so much for the
Thank you.
excellent presentation, so thought-provoking, and really appreciate the chance for all of us here in Ontario and in Canada to hear about the work that you're doing at the WHO. I'd like to also extend my appreciation for everyone who joined us on today's webinar as participants. I'd also like to remind everyone to save the date for the Ontario Public Health Convention, otherwise known as TOPIC, which will be held March 26th and April 2nd in 2025. So please check out further details on the TOPIC website, topic.ca. Thank you again, Natasha. It's a pleasure, as always, to see you, and thanks for coming and sharing this work and this great presentation with us.